Thank you, Nicole. And hi, everyone. I see we've got like 35 people on the line already. I'm sure a couple will be late, but we won't let that slow us down. Thanks for taking time in your afternoon to go over some of these topics with us. I'm going to talk about the FLEX notices of award and some of the key milestones in the next year of the FLEX grant, and then Yvonne is going to review our IndyQuip eligibility for this year. Without further ado, you all received your FLEX notices of award between July 30th and August 17th this year. I really want to commend our colleagues in the HRSA Grants Office for getting all those NOAs issued in such very timely fashion. So this webinar is really going to focus on how to manage your grant and what to expect in the FLEX program in the coming year. I realize this will be familiar information to many of you, but we also have newer people in the grant program, and it's always good to get a refresher of some of the HRSA and federal grant requirements. So this really is not a skills and content training about cost finances or healthcare policy or quality improvement techniques like the Task 90 webinars and the virtual knowledge group calls are. This is grants management from HRSA. We'll stop a couple of times to ask questions during the webinar, but feel free to enter questions in the chat box at any time also. And as Nicole mentioned, your lines are muted by default, so please keep them that way to improve sound quality, but press *2 if you would like to ask a question. So this FLEX grant timeline is a slide I also showed at the reverse site visit, but I wanted to take a look at it again as a reminder for everyone and to help us keep that big picture in mind. So as of today, we're at the very end of project year 1 under the FLEX grant. What to look forward to right away, you'll soon be starting your performance improvement measurement system, more affectionately known as PIMS reports, for year 1 of the grant. And it's also time to start preparing the financial report for the past grant year. Even though that isn't due until January, you can always complete it sooner. And just 6 short months from now in March, you will be writing the progress reports and non-competitive continuations for year 2 progress and year 3 funding under the FLEX grant. This timeline helps illustrate how these milestones keep coming throughout the year. I do want to emphasize a couple of things about that federal financial report. I realize, especially in state agencies, it's often somebody not in the FLEX program office. You have a financial controller's office that's managing the financial reports and writing those for HRSA. But one problem we've ran into in the past, especially when people are looking for carryover requests, is that federal financial reports are either not done on time or require multiple rounds of corrections, and that causes a real problem and can delay or sometimes even make impossible your carryover requests. So especially if you think you might have carryover, 1, let your project officer know right away so we can start talking to you about what you're planning to do, and 2, work with your colleagues who do that financial report to be sure that it's completed on time and accurately. And as a pro tip, if you can complete all the drawdowns and liquidations under the FLEX grant in September and file both the federal financial report and the federal cash transaction report, which goes into the payment management system, file both of those for the end of the quarter that are due in October, and both of those reports reconcile, then you can get your carryover. Then you can get a carryover request approved a lot sooner. If you don't meet that October filing date, the grant has to wait until the next quarterly payment management system report, which comes in January, and so they can't reconcile your federal financial report until January and cannot approve a carryover until the money availability is confirmed. And that whole process can just delay any potential carryover project by several months, if not longer. So just keep all of that in mind when you're looking at financial timelines. I did want to share a couple of interesting points about your progress reports this year. Thank you, everyone, for taking the time to really tell us some things about what you're working on. We learned a lot, and one of the things I really wanted to highlight is that's a record of flex programs really doing a lot of work to improve the quality of care and comprehensively both assess and address health needs in rural communities and critical access hospitals. In your programs, flex staffing ranged from 1 FTE to 4.4 FTEs. In the quality core area, everyone is working on the INVI core measures, of course, and that's a good thing since that's part of the grant requirements. One thing I noticed, many of you are also working on additional patient safety measures. 24 states included optional activities under Activity 1.05. A few states are working on discharge planning, that was 7, 6 on medication reconciliation, and 9 on some of the other additional optional outpatient measures. And in the area of operations and finance, of course, everyone is doing statewide needs assessments to monitor the kinds of needs in finance and operations that your CAUs have. 31 states are doing in-depth assessments with CAUs and cohort groups. 30 states are planning revenue cycle improvement projects, again with CAUs or CAU cohorts. And 26 states have other types of operational project improvement projects. And all of this really highlights that state flex programs are doing a lot to help CAUs improve the value they provide through both quality improvement and financial and operational improvements. In addition to the required quality and finance areas, 34 states assessed population health needs. 15 are planning to assess community health needs, 17 assessing EMS systems, 11 working on population health improvement, 16 on time-critical diagnoses, and 7 on other EMS operational improvement projects. Interestingly, 13 states reported that you expect to be doing some CAU designation activities or studies in the fiscal year 2016 program year. And 16 states, including 2 new members, proposed innovative model development projects for the coming year. Oops, too fast. The other thing I wanted to talk a little bit about is the work plan measures. You all identify measures in the work plans that you're going to monitor for the various proposed activities. That was part of the application last year. The thing we're really looking for in your progress reports this past year and next spring is to report data on those measures you chose. And we're really looking for you to report the measures and data specific to your program, and including baselines, targets, and progress data when it's available. 20 grants have a condition on them to submit a revised work plan, and the most common reason for that condition was lack of data about the measures that you'd chosen. It's really important to emphasize that these are two sides of the same coin. The measure you identify for each project is the question or concept that you're going to monitor to see what kind of difference you're making, but you also need to report the measurements, the data that answer that question or address that concept. And I realize you won't always have updated data, that you have to complete these progress reports halfway through the project year. But use the most recent available data you have and tell us when you expect to have more. Based on what we saw in some of the progress reports, and I'm going to show you a couple examples from the spring of simple data tables that Flex programs use to report their program measures in a really was an efficient fashion. For the next progress report, I'm going to be including a data table as one of the required attachments, and we'll be working with Task to develop a template for that you can use if you like. So those of you needing revised work plans, please work with your project officer. There's some specific issues in various states, and we'll help you understand where we're looking for more information. Here's an example of a data table that Jay in North Carolina was kind enough to let me share. As you can see, this really can be pretty simple. Your program measures, the baseline value you're starting with, the target that the project is looking to achieve, and provide an update of the most recent values when it's available. And this is an example where last March Jay didn't have recent data on those to report. Now, in another program area, he did. He could report rates of CAW, InvQuip measure data reporting, and participation in some of their collaborative projects. It's going to vary from measure to measure the timing and frequency that you'll have data. And we know very well from InvQuip that, especially on these national reporting programs, data lag is just a reality that we deal with. Another important thing for program integrity and for showing the value and worth of the Flex programs is establishing baselines and targets for the various measures that you choose. In this example, Melinda did a great job with the South Carolina application in justifying what her baselines were and where the targets were set. In this particular case, she didn't have new data last March either to include in this report, but she did set baselines and goals. And thanks for sharing this one also, Melinda. And as a final flash example, Leslie in Montana uses this measure data table to track her projects and to report to us. The other thing I want to say about data is that we really do understand some of the challenges you face reporting data on hospital improvement. Your work as the State Flex program is not at all the only influence, and it's often not the strongest influence on the quality metrics and the financial margins in some of these critical access hospitals. And in addition to that, you have a lot of needs in your state and limited funding, and you aren't able to help with everything. I'm not asking you to prove that your Flex work changed nurse-to-nurse communication or days in accounts receivable or healthcare personnel vaccination rates among CAWs in your states. I really do, though, expect you to know what those rates are for your hospitals and for you to track them so you can spot changes over time and identify areas where the Flex program can intervene and help the hospitals to improve. This isn't randomized controlled trial level data that you need to prove causality for a new drug. But at the same time, we also need to collect, as a program, the best data we can, even if it's limited, and even if it is confounded by outside factors. So we really understand that You face a lot of challenges there, and we really appreciate your work in that area. And at the end of the day, let's keep focused on the big picture, that this is improving, these programs are working to improve the health of rural people and the quality and efficiency of rural health care, and bringing value to the communities we serve. So with that, I am going to segue to a quick review of highlights of the Notice of Award. And thanks, Stephanie, for letting me use screenshots of the Idaho NOA as examples for this webinar. Of course, every year you should read the entire Notice of Award carefully. Much of it repeats, but there's always a few things that change, and this really is a binding agreement between your organization and the federal government. But like your paycheck or your tax return, there's a couple of key boxes that I wanted to highlight. So the first thing to look at on every NOA you get is what budget period does this apply to. If you've been involved in the grant program for a while, you know that you can get retroactive NOAs that make changes or deobligations in past program years. And if you don't catch what budget period that latest notice in your email box is addressing, you can get confused. Always check your contact information, name and address, and make sure that's correct. If those are wrong, notices may go to the wrong place. And box 12A is always of interest to people. That is the total authorized financial assistance for this grant for this period. The second and subsequent pages of the Notices of Award go into the terms and conditions. And these are the items. It's a list of things you need to do. They're not generally in any specific order, and please do read them all and ask your project officer if there's things that don't make sense. The final major section on the Notice of Award is the reporting section. All of your grants have that federal financial report requirement. The way it's formatted, I wanted to highlight that the August to October budget period is the one that applies to Flex, with the financial report due in January. For those of you with quarterly reporting requirements, those will also be listed in this section. And then at the very end is contact information, both for you, and make sure that you have the right program contacts listed on that last page, and for your key contacts at HRSA, your project officer and your grants management specialist. So to talk a little bit about the terms and conditions on that Notice of Award, terms are informational items. They generally don't require a specific action in EHB, although they can certainly require other actions and obligations for your organization. As you'd expect, all the regular federal grant laws and regulations apply to the Flex grant. This includes financial reporting, audit requirements, and the new uniform guidance, which is codified for the Department of Health and Human Services at 45 Code of Federal Regulations, Part 75. One thing that I know caused us all some confusion last year, FFATA, the Federal Funding Accountability and Transparency Act of 2006, does not apply to the Flex grant reporting because the original Flex grants predate that law. One thing I want to emphasize, because we've gotten some questions about it, is HRSA requires grantees, all grantees, to acknowledge HRSA grant support in any written products that you produce or distribute. Standard term number 3 is where that will be in most of your NOAs, and has disclaimer language you can use. I want to make it clear that you don't need to calculate individual spending percentages for each sub-project. Use the standard language, your grant number, and the total amount of flex funding in your program, and just add that as a tagline at the end of documents all year long. Another term that you should pay special attention to this year is that CAUs that are not eligible for InvQuip, not eligible for Flex because of the failure to report InvQuip data and that did not request a waiver, will also be listed on the Notice of Award. And that will say the CAUs listed below are not eligible to participate. And I want to emphasize, that's a real change in Flex, and we appreciate you helping to get the word out, and we appreciate your feedback on how we can maintain program integrity with the InvQuip participation requirements while also being flexible for CAUs that face unusual challenges. There are a few Flex-specific terms that you wouldn't find on other HRSA grants that I wanted to highlight. In particular, there's some terms about travel. We highly encourage attendance at the CAU conference in Kansas City, and then we require participation in the annual Flex program meeting. That's the reverse site visit, and another regional or national meeting that informs management and administration of your grant. The PIMS, Performance Improvement Management System, not to be confused with PMS, which is the payment system, reporting is another requirement of the Flex grant. And then there's also terms on there that every grantee needs to provide data if requested for Flex program evaluation, and attend a new staff should attend the grant workshop in Duluth. One thing that's new this year is we've added a term that in the case of prior approvals, you're required when they're returned to the grantee for changes from HRSA, we're asking you to make those changes within 2 weeks because we don't want to drag the approval process out and make it impossible for you to complete the projects. If it takes longer than that, carryovers and other prior carryovers in particular will be denied. So the things on your NOA that will require active action in EHB are the conditions and the reporting requirements that I mentioned before. For those of you that have revisions to budgets, work plans, or project narratives, do talk to your project officer about what needs to be included in that revised work plan. And get our feedback before you spend too much time on it. Generally, you just need to add or adjust specific things to address our questions. You don't need to rewrite the entire work plan in most cases. Many of you have already started these conversations, after all, since the notices of award started coming out the beginning of August. And also, we're happy to review drafts and discuss your approach with you before you submit something in EHB if that is helpful. Task is also available to help you with work plan revisions and provide feedback on project proposals or other questions you have. For the quarterly reports, we've got 17 states this year will be providing quarterly reports in EHB. That is mainly because of high unobligated balances last year, a trend of unspent money, or other concerns identified by your project officers. And we have updated the HSD template for quarterly reporting for FY16. You can download a copy in the sidebar of this presentation, and I also posted the same file in the Flex program forum, so you can get it there if you are ever looking for it in the future. Really, these quarterly reports are because we want to help you keep your activities on track and avoid large unspent balances in the future. And it's a way for you to give us a heads up when plans are delayed and timelines slip. One other thing I wanted to clarify, because I know, especially in state government, sometimes you use this language a little bit differently. When we're asking you about the amount obligated so far in your quarterly reports, this is using obligated in the same sense as it would be on the federal financial report. It's an amount that you know with certainty and that will definitely be paid out with grant funds. For a variable price or variable quantity contract, for example, would generally not be obligated on this quarterly report until after the work is performed, because you don't really know what the actual spending on that contract is going to be. And in some cases, you may not know the exact salary or exact travel costs that applied last month, but use your best estimate. Establishing regular expenditure tracking in your project is definitely a grants management best practice. Finally, the PIMS report, as I'm sure you know, the PIMS format is going to be quite a bit different this year than it was last year. We're really focusing on looking at participation and improvement in flex activities by the cause in your state. This is a grant requirement, and you've got a term on your notice of award actually telling you this. And in many cases, another complication that we're going to encounter with PIMS is the timing. In many cases, the related flex activities that you're reporting on for these causes may have happened last month. You won't have had enough time to know if they have shown improvement or not. For PIMS, you only want to report known improvement, but we aren't trying to prove that the flex activity alone caused these improvements. We just are not in a position to get that kind of data. PIMS will also ask about your aggregate spending in each activity area, and you'll need to allocate non-specific spending like salaries and travel costs across the activities in an appropriate allocation fashion so that you report your total direct costs along with your PIMS activities. The only expense that I don't expect to be included in PIMS is the indirect costs that are specified on that budget on your notice of award. The one other thing, compared to last year, you'll notice that there's a lot fewer questions in PIMS, and we're not asking you to report data that we can get elsewhere. For example, PIMS is not going to ask for CAW and BQIP participation rates because we can get that data directly from the Telligent reports. The final thing about PIMS, the IT developers are still working on it this week. They may finish sooner, but it probably won't be open for your reporting until September 15th. And I'll definitely keep everyone updated through the Flex Forum and the Flex Coordinators mailing list as that gets finalized. Finally, I want to remind you about some of the tools that are always available for Flex Coordinators. All of these are hyperlinks. If you download the PDF of this presentation that's available in the sidebar, you can click directly on them. HRSA maintains a lot of resources for grants management, including their Manage Your Grants webpage and some of the other policy requirements and help centers that are available through that. And then we have a great range of Flex-specific resources, including the quality reports and Compass from the Flex monitoring team. And remember that the secret Compass access page is flexmonitoring.org/compass. And TASK has a really great range of resources on their website. I want to remind you all of the Flex Fundamentals and Core Competencies documents, the Flex Program Forum, where we can share questions with each other, and a whole lot more. And you know how to reach them at task@ruralcenter.org. With that, is there any questions on this section? And push *2 if you'd like to ask a question on the phone or enter something in the chat box. Hearing none, I will turn the next section over to Yvonne to talk about IndyQuip reporting.
Awesome. Thank you, Sarah. So as you know, the IndyQuip requirement in FY15 in the FOA made it required to participate in IndyQuip. And so just like we did a few months ago in March, we're going to go over what the criteria is for fiscal year 2017. So the overview is we're going to go over the goals and status of IndyQuip, as well as what it means to be an ineligible call. As Sarah mentioned that there were a few critical access hospitals that we deemed ineligible, and so we're going to state out what exactly that means for you as a Flex coordinator. And then we're going to go over the fiscal year 2017 IndyQuip criteria. This includes the reporting periods, the waivers, and the resources available to you. So as we all know, the goals of IndyQuip is to report on a common set of rural relevant measures. Ultimately, the goal of IndyQuip is to get 100% reporting on all the measures. Currently, as of this past Monday, we have 1,314 critical access hospitals that have signed a memorandum of understanding to participate in IndyQuip. And after a review of of all the waivers submitted during the NCC period, 21 critical access hospitals were deemed ineligible for FY16 Flex funds and Flex funded activities. So this is what ineligibility means. Ineligibility means your critical access hospital's name will be listed on a notice of award as previously stated by Sarah. Now, the critical access hospital's name can be removed from the NOA at any time as long as the critical access hospital signs a memorandum of understanding and begins reporting on IndyQuip core measures. This also means that the call will not have access to the updated IndyQuip data reports, but will still have access to COMPASS. The state Flex coordinator cannot provide Flex funding to the ineligible call, including but not limited to any Flex funded services or activities where the inclusion of the ineligible call would increase the cost to the state Flex program. One example is listed below where it deals with travel assistance. When it comes to sponsorship, scholarships, activities such as conferences and workshops, an ineligible call may still attend a conference, but will have to self-fund themselves. So a Flex coordinator cannot provide any funding to this call. What a state Flex coordinator can, as well as technical assistance providers can do, is retain the ineligible call on their listservs. But it needs to be made clear that all Flex funded activities are not available to the ineligible call. So this kind of just means when you're sending out an email to your listserv of calls and there's certain resources, webinars that you're providing them, you need to put pretty much an asterisk or note that says if you are an ineligible call, you are not allowed to participate in these activities. You know, you can still provide them with the links to the recorded webinars, and you can still provide outreach and technical assistance such as site visits to these calls for the purposes of assessing needs and barriers to encourage IndyQuip reporting. Now, as you know, we're doing a phased approach to this IndyQuip criteria. FY15 was capacity building. FY16 was reporting on at least one measure in one quarter in at least one of the 4 domains. For FY17, the requirements are a signed memorandum of understanding, and the call needs to submit data on NBQIP core measures for at least 1 quarter and at least 1 measure in at least 2 of the 4 quality domains within a certain reporting period. And so for the calls that had waivers accepted in FY16, you are still held to FY17 criteria. So now I'm going to be going over the reporting periods. So patient safety. As you know, there are 2 measures that fall under this domain, IMM1, IMM2, which is 3rd quarter 15 to 2nd quarter 16. OP27, this one is a measure, but what we're counting as submission is registration of NHSN. So if you have a call that registered with NHSN, that's considered submitting under the patient safety domain. Patient engagement, HCAPS. This is for 3rd quarter 15 to 2nd quarter 16. For care transitions, because we get the data so much quicker than the other measures, it's from 1st quarter 16 to 4th quarter 16. Next is the outpatient. Outpatient will include the ED throughput, the AMI, as well as the patients left without being seen, which is OP22. And these are for 3rd quarter 15 through 2nd quarter 16. But as you can see from these reporting periods, most of these submission deadlines have already passed. So the next slide will go over the reporting periods that CAUS can still report on. So most of them are blacked out already. For patient safety, only 2nd quarter 16 applies, and the deadline for that is November 1st. So you still have a few months to help your hospital ensure that they're submitting data through QualityNet. OP27 is the facilities registered through NHSN. Currently, we have 1,012 critical access hospitals already registered. So there's only about 300 more remaining that still need to get registered. And from what we've been told, it takes approximately 3 months to get registered. So definitely I would start now. Patient engagement, that will only be for 3rd quarter 15 through 2nd quarter 16. And care transitions, you will only have 3rd quarter 16 and 4th quarter 16 to report and count. So that's October 31st and January 31st, 2017. Outpatient, again, it's only 1 remaining quarter, 2nd quarter 16. Okay, so this is the page where it only shows the reporting periods that counts. And so currently from the data that we've been pulling together, only about 50% of critical access hospitals meet this criteria. But I am confident this percentage will increase because of the additions we've made to the NBQIP data reports that does integrate the population and sampling data. Furthermore, this quarter, 2nd quarter 16, was the first time that all 45 states reported on EDTC measures. And so that's a definite improvement. And this is really a great effort made by all of you. So I definitely continue to encourage you to really encourage your critical access hospitals to reach out to Arquita, to use the resources that we have available to you, because it is possible to be able to meet this criteria. And so when we go over to NBQIP data reports updates, there will definitely be more information. Waivers. As you know, just as in FY16, we do have waivers available to every critical access hospital. The accepted justifications for this are critical access hospitals that just signed MOU, certain costs that just received designation. We know a few that are currently going through the process. Calls with extenuating circumstances. If you have any questions to any of these exceptions, definitely just reach out to your project officer. Waiver requirement elements are the same exact as the FY16. You need your cause CCN, cause name, and the reason and situation each cause faced that they were not able to submit on a particular domain. And this is for every domain listed, not just for one, as well as a section for other reasons that don't necessarily fall into each NBQIP domain. Documents that are relevant to your cause waivers are requested. One example is documentation that your call just started submitting HCAPs. For example, we know that it takes 4 quarters of consistent reporting for HCAPs to show changes in your report. And so if you can show that each quarter they actually submitted completed surveys, which is possible if you pull up a report, definitely send those in as documentation. A sample of this waiver will be posted on the task website. Additional information, just like in 2016, waivers must be submitted with the 2017 non-competing continuation application as an attachment, and you should have sufficient attachments for this. Every waiver will be reviewed on a case-by-case situation. All calls will be held to FY17 NBQIP criteria regardless of when your waiver was accepted. Calls are allowed to submit a waiver even if they submitted one for FY16. In terms of whether a waiver was accepted or not, each state flex coordinator will receive notice of this within 30 business days after the 2017 non-competing continuation application period closes. So here are a few resources for you. It's the NBQIP Memorandum of Understanding for your critical access hospitals for everyone who wants to get into the program. All of the information I just stated in document form is in that second link for FY 2017. The sample waivers there as well as the Flex Forum and reporting tools. Also, the NBQIP submission deadline sheet will be updated because we know that some of those deadlines are passing. And that's all for me. Are there any questions?
Press *2 if you want to unmute your line and ask a question.
Hi, this is Kenny from South Dakota.
Kenny?
I wanted to get a clarification on the HCAPs, because I know they have to report 4 quarters in a row before they are on either the NBQIP reports or the hospital compare website. So what I've been doing on the ones that I didn't show up on the HCAPs or on the NBQIP reports, I been contacting them to find out what their start date was, and then from that point I can determine when I should anticipate they should have data on NBQIP reports. But it sounds like we have to verify that on a quarterly basis.
Correct. You can generate these reports on how many completed surveys were submitted through QualityNet when you log in. And so a report can be generated for each quarter. So if you keep track of that, you can track it for the critical access hospitals.
Oh, we're supposed to have a login information on QualityNet?
Well, you will get it from the call.
From the call.
Login for the QualityNet.
Oh, okay. Oh, the
Yeah.
call, they can, but I guess I didn't know we were supposed to log in from the call or log in on there.
You would not be able to. Yeah.
But they're the ones, because basically what I've been getting it from is I get it from their vendor, or they get it from the vendor and send it to me.
Vendors will still have access to generate this report.
Oh, okay.
Yeah. For Mary Jane, the question is they have to report in second quarter 16 to be eligible for 2017. The previous slides that showed the reporting periods I'm only stating that those are the reporting periods that still apply. For example, we already have all the data up until fourth quarter 15. We're still waiting to receive first quarter 16. First quarter 16 reporting deadline ended in August 1st. And so the next reporting period is second quarter 16, which is November 1st. And so that's what I mean, that is one of the periods of reporting that still count for your call. So for example, if they haven't submitted anything for any of the quarters for outpatient, they still have the opportunity to submit in second quarter 16. And then they need to submit in 2 of the 4 domains. And so if they do that, they'll be eligible. So they can either do HCAPS and EDTC, EDTC and outpatient, patient safety, HCAPS, any combination you wish. You're welcome.
Thanks, Kenny and Mary Jane. Any other questions? Please take this chance to ask them. Okay.
Hey guys, this is sorry guys, this is Michelle from Colorado, and I'm just wondering, so if they don't submit by that second quarter with the due date November 1st, and they realize, oh no, we're not going to get any flex funds, if they submit for third quarter, fourth quarter, submit for third quarter on, even though they're placed on the NOA as not eligible, did I hear correctly that we could submit to have them removed so that way they can still have access to funds if they do start collecting the data?
That would fall into the waiver section. And so if they didn't submit for second quarter 16, but you find out that they submitted for third quarter 16, one, you would need the documentation for that, and secondly, you would submit a waiver for them. Each waiver will be reviewed on a case-by-case situation.
But it is, go ahead, sorry.
No, go ahead, Michelle.
I was just going to say, so it is conceivable, though, that that they're like, oh no, and then they do start submitting, that then we can have them removed. I understand we have to do the waiver and stuff like that, but it is conceivable that then they could get access to the funding, right?
Yes, it is very conceivable.
And the reason for those reporting periods for FY17 eligibility is those periods is what we will have data for when the guidance for the new non-competitive continuation applications goes out in probably March. Speaking again of data lag, this is another example of data lag. We won't know in March what facilities reported in January. We'll only know for December for EDTC. So those cutoff dates are so that we can generate a list for you all of the eligible and ineligible cause based on known INBUQIP reporting to give you a chance to request waivers for cause that might be on the ineligible list but have extenuating circumstances.
Great, thanks.
We have a question on the chat room. We have a critical access hospital that received their designation late on August 8th. Should we submit a waiver for them or just make sure we get the MOU signed? What I would encourage you to do is definitely get the MOU signed and sent to your project officer, and encourage them to start reporting on as soon as possible, especially with EDTC getting registered with NHSN. If the hospital is definitely on board and moving quickly, getting all the paperwork through, they may not even need a waiver, since it's the NCC. This will be out in March of 2017, so you still have a good 6 months or so to definitely get your hospitals on board with NBQIP.
That's exciting to have another call, Corey. Any other questions? Well, thank you, everyone, for taking some time on a hot August afternoon to join us for the webinar. Just as a reminder, here's your Flex Project Officer map, and you should all know who your project officer is because you just received the NOA that stated the same thing. Thank you for attending. Just a reminder of all of our contact information. The recording of this webinar will be posted in the Flex Program Forum along with the quarterly report template that, in fact, I already posted a couple days ago. And the MBQuip eligibility criteria and sample waiver are already up on the task website. There's direct links to them if you download the PDF of these slides, and you can also find them on the task website through the MBQuip section. A quick reminder of upcoming events on Monday, so that's this coming Monday, August 29th. Yvonne will be giving us a webinar on the new Telligent reports. There are lots of changes and more information in that new report format, including the really exciting ability to report zeros. So I'm looking forward to that. Thank you, Yvonne. On Wednesday, September 14th, there will be a webinar rolling out the new subcontract management guide that has been developed by Task. This is a tool to help you manage contracts and subcontracts under the Flex grant. The next MBQuip Virtual Knowledge Group call will be Thursday, September 15th. And Omi and I will be at the NRHA CAW Conference in Kansas City, September 21st to 23rd. So if you are there also, please do say hi to us. And then finally, looking to October, the new Flex workshop for new Flex staff and for people who want to study Flex again will be October 17th. Contact Nicole Clement if you have questions about that or to register. And as one final reminder, we just got a report that as of 6 a.m. this morning from our colleagues in the Office of Pharmacy Affairs, only 54% of CAWs that participate in 340B had completed their 340B recertifications for this year. The deadline for that recertification is 2 weeks away on September 7th. And that is actually, I think, fairly common that